Thank you for the introduction. I'm Dr. Murphy. I've actually been one of the team physicians at South Carolina for about 3 years. I was at Clemson for 7 years prior, and this is actually my last 2 weeks at USC. I'll be going back to Clemson as one of their team physicians again. I'm happy to be here. I'm going to try and get through 2 really big topics in a short period of time, but they run hand in hand, and if you're going to be dealing with any of your adolescent athletes, you really need to be able to handle both of these topics. We obviously have no disclosures, and your objectives were in the handout. These 2 topics are really important, especially as we talk about the exponential increase in our female youth athletes. We know they're increasing their participation, but at the same time, we also know how many benefits come to their participation, keeping them involved through that middle school and high school years. So please continue to encourage them, empower them as female athletes, and make it a part of your practice. They're enjoyable to take care of, and it's an incredible opportunity to be a part of their success and help them achieve their goals. PPEs, we've actually been doing them for a very long time as a profession. They haven't evolved very far. The original onset was looking for congenital heart abnormalities, and that's still a primary focus. Around 2007, we did have the ability of the AHA to come in and give us their 12 screening question guidelines, and we've continued to grow on that. If you look at the AMSSM consensus statement, there's kind of a reading between the lines of whether or not to do EKGs, and we'll get into that a little bit. But understand, why do we do them? This is an opportunity for you to at least get these patients in front of you once a year, and not in a mass participation setting where they can have that intimate discussion. You can talk to them about all the aspects of their healthcare, not just their athletic participation. Purpose of doing these, we're not trying to DQ student athletes, we're trying to identify limiting factors, whether it's injury, illness, surgeries that they potentially could need, but picking up on asymptomatic illness, modifying activities to help them participate better, but be able to make these recommendations and helping them access healthcare and approaching the legal liability issues. I also the reason I don't like the mass participation setting, which unfortunately I end up being involved in quite a bit, is I like to use these office visits as an opportunity to discuss preventative medicine, talk about all the other things in their daily life that they need to be focusing on their healthcare, not just their athletic participation. So take advantage of the opportunity. Don't just see it as a quick, oh, this is a 5-minute in and out visit, I'll get through it and move on to my next patient. Make sure you're talking to them about PED use. Make sure you're talking about proper technique. But it's really to facilitate that safe participation and encourage them. They don't have to be the star player to participate. It's getting them involved, keeping them active, especially in those teenage years. Biggest thing on this slide I want to talk about is that time off, that sport specialization. Kids, especially baseball, gymnastics, a lot of these kids are coming in and they're playing one sport. Talk to them about doing other sports. Most of your overuse injuries come from these kids who are doing one thing year round and way too many hours during the week. Your majority of professional collegiate athletes played multiple sports in high school. They didn't specialize when they were 6 years old, and they weren't worried about college scholarships when they were 7 years old. So talk to parents about time off, talk to parents about not focusing on that sport specialization. It's easy for them to get caught up in it when everyone around them is putting the emphasis on travel league baseball. Again, make sure you've talked to them about understanding what sport they're in, the equipment they're using, the technique that goes involved in it, talking about not tackling head first. Kind of get a grasp of what sport they're doing and be able to talk to them about all the implications of that. So one of the reasons we do PPEs is obviously the sudden cardiac death screening. It is sensationalized in the media. It is a heart-wrenching story with every student athlete that it happens to. So if you just Google sudden cardiac death, these are the first 9 images that come up, and it's thousands of these pictures. You're not getting medical images, you're getting individual student athletes. These are important to do. The caveat to that is the data is limited. There's about 310 studies that, if you go and do a systematic lit review, limited prevention of morbidity and mortality. However, it's an opportunity to do education for these patients, and sitting down and talking to a patient, if that prevents one death, it's worth seeing your patient. We're not spending tons of money just to see them and take care of them and do preventative medicine. Part of the reason they're not effective is state to state, they determine what the route and how often these PPEs have to be done. So there's inconsistency, and not everybody's following the AHA 12 question screening guidelines. So if you're not doing them right, no, they're not gonna work. So that's why being in front of a group of primary care providers who can be out there in front of the sports medicine physicians and doing them correctly and capturing more kids instead of them going to an urgent care and getting them done the day before practice starts. That's what we're trying to prevent, and then it will become more effective if we're all involved. This is, if you want to look for a book. Just looking at the number of participation, back in 2014, we had almost 8 million high school athletes. This is continuing to increase. We've seen a downslide in football. It's kind of tipping back up. You're going to see this waiver, but you can just see by the sheer number of kids involved that they're going to cross your path. Generally, you can look at a 1998 study, even out of 3,000 participants, only less than 2% were DQ'd. So we're not trying to disqualify these kids from activity. We're trying to help them participate in a safe manner. Not every sports medicine physician has to see every student athlete. This can be done by the primary care providers and should be done by the primary care providers. You guys know them best and can often solicit more information and be involved in their care along the way. We use physician extenders a lot when we're doing them, and as long as we've had a conversation, you understand the process, it's a great opportunity to get involved at any level. So how often? South Carolina, we do them annually. Different states have different recommendations. As a collegiate team physician, I like to lay eyes on all of our student athletes every year. That's personal. That's developing that patient relationship with them so that when they do need something, they're not afraid to come to me. But I recommend yearly. Definitely at least 6 weeks prior to the start of that season, because if there's a conditioning issue, if there's an injury issue, you want time to assess it, help them recover, make sure they're not going out deconditioned into August football practice, putting themselves at more risk. Again, if you want more information from a South Carolina standpoint, the South Carolina High School League has their own form. That's a good example of the right way to do it, and they do recommend annual. Sorry, these are mold slides. So where to do them, you kind of already heard my thoughts on that. I think these should be in the office. I think you should have one-on-one time, be able to do your general medical and your orthopedic evaluation, have time to do preventative care. This is a little more costly. It's harder for patients sometimes to get in to see us as physicians. But I think it's a better setting. It creates a sense of privacy and intimacy with the patient that you can actually get more out of them and spend more time with them. A lot of times you'll see, especially at the high schools, this station approach where they bring in all kinds of providers to do vitals at one station and gen med exam one station and orthopedic exam, and then there's somebody at the end to sign it. I don't like that because I don't like being the one signing something that I didn't actually do the work, and I think it creates, especially for adolescent kids, an environment that's not necessarily comfortable for them. They're just getting pushed from person to person who are strangers to them. Most of them don't come with their parents, so the accuracy of their form and their answers is questionable. So I try and steer people away from this. Now, if you're trying to get through 1,000 kids for a community and that's the only opportunity you have to help these kids, yes, do it. But if you can do a one-on-one, I would prefer that. We have the questionnaire review, so on one side of your sheet typically is all of your history questions, and on the back side will be your general exam. The biggest thing is the 12 cardiac questions, and then I will always re-ask those questions to the patient. Do you get chest pain when you're working out? Do you feel like your heart's beating funny? And when your family dies suddenly for any unknown reason? And you'll be surprised how many times they check no on their paper, and then they say yes when they're talking to you. So even though they've filled out the form, review it with them, re-ask it in simpler words sometimes, and re-ask it of the parents. You'll be surprised how many times they give you changes in answers. You can see the 85 study, even back then, 20 to 40% match of answers between kids and parents. Kids and parents don't talk. I've learned that. It's even worse. To re-ask and ask the parent, have them in there with you. The ortho part of the exam, that's the easy part. That should take a couple minutes. But it's really that cardiac medical history that we're getting at. I always ask, any recent injuries, illnesses, surgeries, and I try and state that within the last 6 months, re-asking any daily medications you take, because they often don't think about it, especially our ADD, ADHD kids. When they get to me at the college level, they've been on it forever, they don't think about it, and if they don't tell me and I don't have proper documented testing, like real 2-day psychological testing, they're going to fail their drug test and get removed from competition. So it's imperative that you re-ask that question of your patients, and you don't just rely on the sheet. Sickle cell trait, especially in the Southeast, this is on all of the South Carolina High School League forms, but again, something you want to ask. You'd be surprised how many people check no, and then, oh yeah, I think my mom told me when I was born I had sickle cell trait. These kids are at an increased risk, even with trait, of sudden cardiac death. It's a very important question to re-ask. The NCAA requires sickle cell trait testing on all of our student athletes because of previous incidents in the Southeast region of sudden cardiac death at the collegiate level. Again, medications, I can't emphasize the ADD, ADHD meds enough. Educate your patients on how to take them around athletic participation. If they're playing baseball, it may be a medicine they want to take 30 minutes prior to actually playing. If they're picking dandelions in the outfield. Some of your other sports, you may want to tell them, hey, this is a medication we hold off on game days. We don't want to increase that heart rate. We don't want to have a bad outcome. Generally, under the age of 30 with sudden cardiac death, we're talking about HOCM, hypertrophic cardiomyopathy, anomalous coronary disease. Over 30, more coronary artery disease. I use Pistol P as an example. He's one of those odd athletes that actually had a single coronary with dilated cardiomyopathy. So sudden cardiac death comes in all shapes and sizes at any age, but just kind of be aware of what's common with our younger athletes. Non-cardiac sudden death. This is the one we've seen the most recently is the heat illness. If you have an interest in heat illness, look at the Corey Stringer Institute. They're doing phenomenal research on it, but really educate your kids who are going out football, soccer in August. Make sure they're conditioned, make sure they understand hydration. Work with your athletic trainers to have a heat illness plan in place, emergent care, because all this needs to be done on site, rectal temps, ice water submersion before EMS even gets there. Rhabdo, sarcoid, your exercise-induced anaphylaxis, red ants, we've seen that. So understand all the non-cardiac risks as well. The majority of your sudden cardiac death is going to be HOCM, about 75%. And unfortunately with HOCM, your first symptom is death. So the screening questions become that much more important. If you have a patient with a first-degree relative who has had a sudden cardiac death or an unknown reason for death, make sure you've really talked to them, really listen to their heart, listen for those murmurs, screen them appropriately. So I mentioned the 12 AHA questions. These are the things to hit on from an exam standpoint. Making sure you're palpating femoral pulses, bilaterally, you're getting bilateral blood pressures, listening for that heart murmur, you're listening seated and supine or seated and Valsalva, you're trying to change that intrathoracic pressure to change that gradient across the valve to get that change. So if you hear a systolic ejection murmur while they're just sitting there and it's 2 out of 6 and they get up or they Valsalva and it goes away, that's a good thing. That's a benign systolic ejection murmur. If it gets louder, if it's still there, you're going to want to address that further, whether it's echoing themselves or referring them to cardiology. So from an AHA standpoint, again, questions I ask, are you getting more fatigue compared to your teammates? Do you feel like your heart's beating funny? Has anybody else ever told you have a murmur? You're going to want to make sure you've re-asked these questions as you're going through your PPE. Family history, that premature death before the age of 50, secondary to disease in a first relative, disability from heart disease in a close relative, and then any specific cardiac conditions, Marfan specifically, HOCM, long QT syndrome. Again, listening for that murmur, that seated, supine, Valsalva, femoral pulses, and also looking at your physical stigmata of Marfan's. This is one that by the time they get to us, we see more of, because these kids tend to be really physically fit for certain sports. So the volleyballs, the basketballs, we have to be really careful looking for that stigmata. So you get worried on your cardiovascular exam, things you can do from a primary care standpoint, syncope, near syncope, chest pain, palpitations, exercise, shortness of breath. Start that workup within your office. If it's a known congenital cardiac issue, myocarditis, coronary amylase, you're going to get cardiology involved on the front end. But most of these kids, do an EKG, echo, stress echo, you'll be able to clear them. But don't hesitate to say, hey, we're going to take a little bit of time. I'm not going to clear you right away. Let's look at the heart stuff just to make sure. Just put them at ease and tell them, you know, I explain to them, this is why we do this. I'm not trying to keep you from participating. I'm trying to make it safe for you to participate. And they're generally understanding. Other things we look at, vital signs, obviously, height, weight. This is just good from year to year. And then a good pulmonary, skin, abdominal exam. And then your ortho, range of motion, stability, strength of all joints. We don't do hernia checks for anybody that ever doesn't like doing physical exams. Ask them if they've ever had a history of an undecided testy, or they only have one testicle, or they've had an injury. Yes, you're going to document an exam, but if they don't have a history, you don't need to do it. Just document their history questions. And then you're trying to make your recommendations. Understand what kind of sport your patient is playing. Are they doing a collision sport? Is this a limited contact sport? Or is this non-contact? And then is it strenuous, moderately, or not strenuous? Are they playing golf, or are they going to run marathons? So understand where they fall in that spectrum and limitations. So when we say cleared, we'll say cleared for all participation or for all sports, or we'll put caveats to that and limit what they can do. So again, cleared with restrictions. Do they need follow-up, or are they just generally DQ'd? I don't like to say DQ'd till we've gotten to that very, very, very end point of a workup and we just know it's not safe for you to participate in a sport. So something comes up and you decide not to clear them. Factors to take into consideration: are they at increased risk of injury? Is somebody else going to be at increased risk of injury? If you have a pitcher that can't see out of one eye, are they going to beam somebody in the head with the ball every time they try and throw it? Just take that into account. And then is there a way to rehab them, meds, bracing, to keep them below treatment, keep them participating? A good example of this is we always monitor blood pressures. You know, is this a kid who needs weekly blood pressure monitoring with his athletic trainer, but he can participate throughout the season? So that way you're monitoring it, and then if it needs treatment, you can provide that intervention. Just have a plan. And that clear or not clear, we have to be careful because everything becomes litigious. Kids will sue to not participate, kids will sue to participate. So keep them involved in the process. The more you're open and transparent with your reasoning and they understand where they're going on the pathway, the better they are about following recommendations. Now, I've had a kid get DQ'd at one major university, transfer to another university, try and play there, and then sue that university because they wanted to DQ them. So if kids want to play, they're going to keep fighting it. You as a provider have to protect them. Whether it's not always fun being the bad guy, but if it's not in their best interest, then do the right thing and protect them from themselves. HIPAA gets tricky. They provide for this cleared, not cleared, that can be given to the school, but it doesn't provide any communication as far as medical issues. So if it's something you feel needs discussed with the athletic director or coach, get a signed release of information. HIPAA does not give you this global ability to talk to everybody involved in that student athlete's care. What we do at USC is when the student athletes get there, we actually have a global release of information signed by them so that we can communicate through their 4 or 5 years of they're there about any medical issues between myself, the athletic trainer, coaching staff, within reason. If it's something personal, obviously that's not going to get discussed, but think about that before you just start communicating to people involved within athletics about a student athlete. So when to DQ, it's dynamic. You're never going to know definitively yes, no. It's getting through that process, going through the evaluation. But if you're going to DQ somebody, it's a firm DQ. Just stick to your guns. Don't let them try and negotiate. Do the right thing by your student athlete. So again, when to refer. When that murmur kind of gets to that 3 out of 6 level, if it's a diastolic murmur, worse with provocation, these are things you're going to want cardiology to get involved in. And then we get to screening EKGs. If you look at the AMSSM consensus statement and you read between the lines, they're basically recommending screening EKGs, at least at the collegiate and professional level. High school gets tricky because you're talking about millions of student athletes. So if you tried to EKG every high school athlete participating, think of the dollars that would go into that. And is there really validity in screening as far as picking up true positives? We have a lot of questions about this. It's probably the topic that comes up the most at our national convention. Should we do them? Who should be getting them? Who's going to pay for them? Are they effective? And when we're talking about a screening test, these are the typical questions you're going to want to ask. And then we know there's the athletic heart. Are their EKGs going to be different? What do we do if it's abnormal? And then you go into thinking about what are all the things that our younger kids are dying from. Maybe we should be talking about wearing their seatbelt at their PPE, because that's probably going to save more lives than doing an EKG. So we got to take it into context. Yes, sudden cardiac death becomes sensationalized, and it tears at every community when one happens, but it's such a small percentage of our young kids that are dying that we need to be thoughtful in how we make our decisions. We need to also take into account that these are all abnormal EKG findings, but normal EKG findings in your athlete. So if you have an athlete come in, they're complaining about chest pain, and you get an EKG that has any of these findings, that's normal. They don't necessarily need rushed off to cardiology. And that's why it becomes so tricky doing EKGs on these student athletes. So this is where the Seattle criteria came out of. Kim Harmon and her group out at University of Washington have collected thousands of EKGs on student athletes and developed these criteria that they actually have machines. One brand's called a HERNIA, that is an EKG machine that bases their read on these abnormalities. That being said, just like any EKG you read, don't base your reading on what the top strip says. Be able to identify these criteria yourself. A good example, we look at this convex ST segment elevation, inverted T waves through V1 through V4. This is normal. In an African American student athlete, normal. You go to this slide and you start getting those big T wave inversions, V5, V6. This is definitely abnormal hypertrophic cardiomyopathy. But if you're just in your clinic and you haven't recognized that both of these patients are athletes, you're probably going to think both of them are abnormal, and they're both going to end up with pretty significant workups. Great place to practice these. BJSM has EKG athlete learning modules. It gives you a good practice with that Seattle criteria. I'd recommend doing these if you're going to be seeing any student athletes. You get CME credit for doing it. The data on the Seattle criteria actually led to an increased specificity and 74% reduction in abnormal EKGs. Still picked up, in the study they did, it still picked up on the 3 athletes out of more than 1,000 who had an issue. So we limited that waste of extra resources that we're worried about right now if we try and EKG everybody. There's still a high false positive rate, especially in African Americans. But the low incidence of disease in abnormal EKGs is pretty significant. So we're decreasing that dollar per athlete spent as far as workup involved. But even in decreasing it, you're still looking at a couple $1,000s per athlete when it's all said and done. Let's get through these. Okay, so what's being done in the NCAA? I've worked in the ACC and the SEC, and we are all EKGing our athletes. We just, at that level, you can't afford the liability that's involved, and we have a much smaller patient population. We're talking about, we have 600 athletes at USC, EKGing them when they first get there, and we have 2 of our own cardia machines, and our physicians are reading them. So our cost is fairly low from an overhead standpoint. And we had about 10 this year that triggered further workup out of 600. We had 1 abnormality that needed eval'd. In my mind, it's worth it. The general public may disagree with me from a cost standpoint, but it's a work in progress as far as what's the right thing to do from an EKG standpoint. The logical approach would be doing your high-risk athletes. We know football, men's and women's basketball are your highest risk. The problem with that is we have a lot of international students that come over. We know there's certain electrical anomalies that happen within the Italian culture and European culture. So to not screen certain sports when you know there's risk coming from other places, it would just be too high. And unfortunately, there's not a lot of American data. I think this is a great opportunity if people are looking for opportunities for research to really dive further into EKGs and student athletes at every level. UVA did one, and the crux of it is the marginal cost of EKG per diagnosis was about $70,000. So again, I think we need to look at this more, but their study did predate the Seattle criteria, just to keep that in mind. And again, the legal issues that go along with all of this, failure to adequately screen a patient, but then the failure to diagnose an athlete becomes an issue, as well as unfair restriction from sport. So just understand if you're adding EKGs into your practice, how it fits in, and it's not a perfect science. But if, with or without the EKG, if you suspect anything from a cardiovascular standpoint, don't hesitate to step in, hold your student athlete, complete further workup, and do the right thing by your patients. Another interesting thing we can talk about is point of care screening ultrasound for HOCM. A lot of ultrasound techs are wanting to do just kind of quick ultrasound screens. The data with that's not great. You still really need, from an athlete standpoint, a full screening echo looking at all 3 aspects of the ventricle wall, especially outside of the septum, and then also looking at coronary artery takeoff, because we know coronary artery anomalies are a big contributor to sudden cardiac death right behind HOCM. What are we doing at USC? We're actually echoing every student athlete when they come in now. The data, again, doesn't necessarily support. It's becoming more of a, what are your peers doing? And you fall into that kind of legal pitfall. But we, rather than just sending all our kids over to get an echo, we opted to work with a company called Athlete Heart that does athlete-specific echoes. It's about $125 per student athlete, so you can see the cost involved in that. But it goes directly to our cardiologists. They have the images, they're involved in the process, reading them, and then if they need further workup, they're already on board. The question to this is, and my partner and I get into this debate all the time, is how often do you do this? We're talking about 18-year-old student athletes when they get to us. We know over that next 4 years, their heart's still gonna evolve. So I'm of the mindset, if we're gonna do it on year 1, you need to repeat it, at least their junior year, one more time while they're there, especially in a high-risk population, whether it's your footballs or men's and women's basketballs. But the person that pays the bills wants to do them once. So you can see, we don't have a perfect answers for it at all, even when we're kind of trying to dissect the data. Again, get involved, do PPEs with your student athletes. It's a great opportunity for you to get them into the office. These are kids you're not necessarily going to see, and be a part of their success. Encourage them, empower them to stay active, especially your young ladies. Once you've got them cleared and they're out there participating, I want you all to understand concussions, not just because my practice is overwhelmed with them and they can't even get to us in a timely fashion. There's only 2 of us really seeing concussions in the center of the state, and we're getting it all funneled to us from hundreds of high schools and the surrounding colleges. But too many times, concussions get to us, and a primary care physician or an urgent care or an emergency medicine physician has told them, just rest and stay home from school, and they've been home from school for 6 weeks. And then we're trying to undo everything that's been done. Understand on the front end the recommendations and the guidance you want to give them. I think concussions has become this big dirty word because of how it's portrayed in the media, and everybody wants to talk about it, but nobody wants to educate parents, nobody wants to educate schools, and really understand what's going on with these kids. We're seeing millions of concussions a year now because people are more aware of it. The problem is probably 75% of them go unreported because kids don't want to say anything. And they're not easily tracked, so we don't have great numbers. But you can see even a reported incidence of 1.6 to 3.8 annually. That's a large number of head injuries to not be managed appropriately. When we talk about concussions per injury per sport, this is a slide I want you guys to understand the most. Everyone wants to talk about football. In our adolescent kids, your women's soccer and your women's basketball, their likelihood of having a concussion is 20% compared to your football players of 10 to 12%. So these young ladies need identified, need proper care, and they need the assistance in getting back because females take longer to heal from a concussion standpoint anyways. But be aware, it's not just football. So most of your patients are just going to come in and say, I got dinged, or I'm dazed, or I got knocked out. If you hear this terminology, your red flag goes up. If you're on a sideline and a kid says, oh, my head hurts, or they ask the athletic trainer for Tylenol, I see that all the time. So I just kind of mosey my way over there and say, oh, why do you need that Tylenol? Ask them, because they're not going to automatically say, hey, I have a concussion. Most of your general public, even as much as we're talking about it right now, they don't think a concussion is a concussion unless they've lost consciousness. They don't think it's a big deal. They think if they get hit in the head again, it's going to make it better. This was a study in 2008 in the Neuropsychology journal. 40% felt like a second blow would heal them. I can't make this up. So the definition of a concussion, which actually came out of the Zurich conference in 2008, it's complex. It's a complex pathophysiologic process. It affects the brain. It's induced by traumatic biomechanical factors. It can be a direct blow. It can be an impulse blow. We see the majority of our concussions actually from car accidents, from that kind, coup, contra coup injury, and they take the longest to heal. So it's not just your student athletes that you're going to be talking to us about. It's a rapid onset of that impairment of neurologic function. It's functional disturbance. It's not always physical. And it can be a graded set. We don't talk about mild, moderate, severe. We don't talk about grade 1, grade 2, grade 3. Yes, there's a spectrum of the severity of their symptoms, but we want every patient to understand that a concussion is a concussion is a concussion. There is no such thing as a mild concussion. If you have a head injury, we're going to treat it like a head injury. So how are these kids suffering? What's happening is you get this axonal stretching that releases this glutamate. Glutamate makes a spike in your sodium, or in your potassium and your chloride, and then you're in this hypermetabolic state. And the healing is trying to get back to homeostasis. We talk about second impact syndrome, and you have this hypermetabolic state, and then you get this rapid increase of intracranial pressure, which puts these student athletes at increased risk. That's why not letting them go back if they're still symptomatic becomes that much more important. When they present, and if any of you have seen concussions, no two concussions look the same. Yes, there's this kind of cluster for each group. We get cognitive symptoms, meaning they're foggy, they can't concentrate, they're having trouble getting through their work. They have sleep dysregulation. Either they're sleeping all the time, or they can't fall asleep, or they can't sleep at night, but they're sleeping during the day. They get mood disturbances, irritability, anger, anxiety, depression. And then there's somatic symptoms, the visual, the vestibular, the light and sound sensitivity, the headaches, the dizziness, and they can overlap in any way. I like to explain to my residents, my fellows, when I'm talking about concussions, if you think of a concussion as a tree and the head injury is that trunk, you can have a ton of different branches off that trunk of symptoms, and it's going to look different for every patient. How you approach your evaluation, your treatment is going to be based on the symptoms they're telling you. Most of them will come in saying headache, dizziness. That's a frequent presentation. The headaches is dull, it's achy, and it throbs. It gets worse when they're starting to try and do intense cognitive or physical exertion, or they complain about light or noise bothering it. Patients with prior migraines, be sure to tease out, does this feel like your migraine, or does this feel different? Because their migraine headache will feel different. Males tend to get into a lot of the confusion, disorientation, amnesia. Females are more in that drowsiness, kind of sensitivity to noise. They get surprisingly very emotional. And I know that in teenagers, I have this conversation with parents all the time. Teenagers are tough, but concussed teenagers are even worse. They are just emotionally all over the place, and they'll come in tears, so upset about being so emotional, and you just have to reassure them that that is normal. That is part of your concussive pathology. So if any of you do sideline management, if you have a kid that gets a head injury, you're worried about concussion, obviously your ABCs from a medical evaluation standpoint, making sure they're stable. If they have any kind of neck pain, cervical instability, numbness, tingling, you're gonna spine board them. Those are kids that are gonna get treated a little bit differently. If you're out in the field and their neuro exam is essentially normal, you're gonna help them off the field, and then you're gonna continue your concussion assessment on the sidelines or in the tunnel. I don't know if any of you go to any USC games, but you'll see kind of our tent pop up that we take our kids into, so we don't have to take them back in a tunnel anymore. But it creates a private environment where you don't have 80,000 people trying to figure out if somebody's got a concussion. Again, things we're going to do quickly: determine if the patient qualifies for imaging. There's two good sets of guidelines. The one I go by is the Canadian CT guidelines from a head injury standpoint. Not everybody with a concussion needs image. The majority of them don't need image. So they don't have neurologic abnormalities. If they aren't progressively worsening in front of you, don't just automatically send them for a CT scan. Take your time. We do a SCAT-3, which is your sideline concussion assessment tool. It's a whole lot of questions, and I'll show you the sheet in a minute. And then we do what's called a BESS, or a balance exam, where we're looking at their balance compared to where we did their baseline. And then also do what's called a VOMS test, which is your vestibulo-ocular motor system assessment, which most often is the predictor for us. It's one kids can't fake, they can't lie about it. If you're seeing vestibulo-ocular abnormalities, they're not going back in. So again, do you image these patients? If they have normal mental status, they had no loss of consciousness, they're not vomiting, it wasn't an extremely traumatic neck snap injury, they don't have signs of fracture, they're not going to get imaged. You're going to end up with a normal CT scan and having radiated a young kid for no reason. So negative predictive value in the Canadian study was 99.95%. That's pretty good. So I'm going to feel comfortable not CT scanning somebody. And this is a conversation you need to be able to have with parents, because right now parents say, well, do they need a CT or MRI? No, they don't. Be able to explain to them why. So then you've gotten through that kind of initial aspect. My first questions are, do you have any history of migraine headaches? Do you have any history of ADD, ADHD, learning disabilities? Do you have any history of anxiety or depression? Do you have any family history of anxiety or depression? Those simple questions become red flag markers. If they can say no to all of that, the likelihood of them healing within 7 to 10 days is about 75%. If they're saying yes, you can on the front end say, this might take a little bit of time. So just a couple quick medical history questions give you a good foundation to be able to help this patient going forward. So we then get into that physical exam, and this is that VOMS, that vestibulo-ocular system, and we look at smooth pursuits, saccades, convergence, pupil reaction, and that gaze stability. There's a great video of this if you want to go look up further. I just didn't want to waste everybody's time playing a video. And you can score these 1 through 2 or 0 through 2 on each set, and then give them a cumulative score at the end. If they have any abnormalities on their vestibulo-ocular exam, they are concussed. Don't, no matter what they tell you from a symptom score, don't let them go back in. Don't let them resume their sport until they've become asymptomatic on this exam. This is your best exam, so you can see you have the patient 20 seconds at a time. They're standing feet together, eyes closed, non-dominant foot, eyes closed, and then dominant foot in front of your non-dominant foot, eyes closed, hands on hips. And you lose a point every time you kind of wobble, or if your hands come off your hip, or if your foot kind of touches down on the ground. We do baselines on these for all of our student athletes, and then we have a comparison. But even without a baseline, this is still a good, quick, easy way in the office to assess where they're at. Because if they're putting their foot down 10 times, their balance is clearly affected from their head injury. You also want to look at just your general neuro exam, cardiovascular exam. We know there's some autonomic dysregulation with concussions, so just looking at kind of heart rate variability and how they're doing. So the SCAT, we do these in office. So I get the best, I do my VOMS, I repeat the SCAT, or that sideline concussion assessment tool, and you can see there's a symptom evaluation, and they score 22 symptoms from 0 to 6, and then you add up the number of symptoms. You also add up the total number of points they had, and then you do kind of orientation, you do remote and recent recall, you do months of the year backwards, you do serial numbers backwards, and these all score. And the nice thing is when you have a baseline, you can compare to that. But even without a baseline, you'll notice abnormalities staring you in the face from this. So if nothing else, in a primary care physician office, if you can do that vestibulo-ocular exam and do a SCAT on them, you are light years ahead of what we're seeing now come into us from offices. The other thing you'll probably hear about is neuropsych testing. This is your impact testing, Axon, Cogstate, and that's the computer-based visual response, motor response testing. A lot of people see this as the gold standard. There's data looking at it now that, yeah, it's a useful tool, but don't rely solely on this in making your diagnosis and making your return to play decisions. Kids tank these on purpose on their baseline, so then they come back, even with a concussion, they end up doing better. There's ways to cheat this system. It's not something I don't even like using it in our sports clinic. Parents like it, and we use it as a tool, but if you're investing in something from a primary care standpoint, I wouldn't necessarily go this route. So impact testing, they do 6 modules. They're looking at word memory, design memory. They do symbol and color matching, 3-letter memory. And you can go online and do the training through Impact and become certified. And then it gives you a 3-page scoring sheet. And from that scoring, you can break down kind of where their deficiencies are. Again, it's helpful. It's a tool. It takes a lot of time. And if you don't need to be doing it, I wouldn't necessarily. It's just more. So you've diagnosed your concussion. They've come to you. What are you going to tell them? So that first kind of 48 hours, you tell your patients you rest, take it easy, don't do your schoolwork, Tylenol for headaches, try and stay away from NSAIDs. After that 48-hour period, don't just let them lay around. Don't just say cognitive rest, physical rest. We're promoting and we're seeing better medical studies looking at active recovery. So getting them engaged back into school, getting them engaged in cognitive activity, and even sending them to physical therapy for vestibular rehab, ocular rehab. There's what's called a Buffalo treadmill test, where we can actually get them walking. If they can't walk, we bike them, just to get them their heart rate up to that kind of sub-threshold where they'd be symptomatic, so around that 120 range. So you're making them work, you're getting blood flow, but you're not overly exerting them, because we know they're in this hypermetabolic state, they're using up ATP. We're trying to conserve their ATP, but keeping them physically moving and keeping them cognitively engaged actually helps in that recovery process. We just don't want to overextend them. So I always talk to them about staying hydrated, eating healthy, staying on a good sleep pattern. So if it's a kid who's overly fatigued, take short little naps during the day. Set your alarm for about 20, 30 minutes, and then go to bed at the same time every night. It's okay to do like melatonin, get up the same time every morning, and trying to get them into that good sleep pattern. Parents often ask about omega-3s in addition to other medications. You know, it's marketed as brain armor. There is data looking at brain function and omega-3s. It's not going to hurt anything. If they want to start this, we usually recommend it. There's limited data suggesting it helps, but with something that's not going to hurt, and if it gives them that feeling like they're doing something, I'm not going to disagree with going that route. So how do we get them back in? That return to play protocol becomes that much more important. So say your kid is in that 75%, they resolved within 7 to 10 days. They did everything you told them to do. They rested the first 48 hours. They eased back into school over the next week. They've been out walking the dog, or they've been riding a stationary bike and they feel okay. And they've said all of their symptoms go away. They do not return to their sport until they have completed that 7-step return to play protocol. So step 1 is being symptom-free. They've done that. Step 2 and 3 are cardio days. So we talk about light cardio and then a more intense cardio. And then the 4 and 5 is anaerobic, so weightlifting. We do kind of light weightlifting or light anaerobic, and then more heavier. Then you get to sport specific, those last 2 steps. You do non-contact sport specific and then contact sport specific, so a full go practice. They don't go and participate in a game until they have completed all of those steps. They have to do them all symptom-free. So if they don't get through step 3 or step 4 symptom-free, go back to step 2 if that's where they were symptom-free. Sometimes it sounds like it can get dragged out. It can, but we know, especially in adolescent brains, there's a good study out of Wisconsin a year and a half ago that looked at even once a student athlete is symptom-free at an adolescent stage, they're still a week away from being fully recovered. There's that week time frame that they're in jeopardy of that sudden impact or a subsequent injury. So that return to play protocol not only helps them advance back, making sure you're not recreating symptoms, it also protects them from a second injury. I like to have a handout of that return to play guideline to give them. The great thing is, state of South Carolina, all the public high schools are required to have a concussion plan in place. So all of these schools should have a return to play protocol in their athletic training room, and their athletic trainer should be in charge of implementing it. The pitfall we run into is the way the legislation's written is student athletes just need a note from a doctor saying they're cleared. So if they come in after seeing somebody down the road at an urgent care at 10 at night because their symptoms went away, and that doctor just said they're cleared, they're saying they're cleared that they finished their return to play protocol. And we see parents doctor shop like that all of the time. And the way we usually find out is an athletic trainer either calls us and says, "Did you clear my student athlete? Because I haven't seen them do any of their return to play," or that student athlete ends up seeing us in clinic for a second head injury and they're significantly more symptomatic, and then they finally tell us, "Well, I wasn't really fully all the way better before so-and-so cleared me." So we need all of primary care providers at every level in the state to work with us, because if we're getting undermined, we can't do our jobs to help protect everybody. And not every student athlete is going to see a sports medicine physician. We're relying on the people around us to manage concussions correctly. And unfortunately, there's just not been enough educational opportunities for everybody to understand how we're managing them currently. So the ZERT guidelines, this is that return to play protocol, just written out a little bit more. And then your high school athletes especially, each step takes 24 hours. It gets a little more liberal when you get to the collegiate and professional level as far as how quickly you can move to that next step, but we know we're dealing with adult brains at that point. It's always better to err on the side of caution with your student athletes in that middle school, high school age. This is just a good example of that 75% we talked about. The majority of your kids, if they do the right thing on the front end, they're gonna get better. If they haven't gotten better in that 7 to 10 days, so you saw them kind of, day one after they went to the ER, you explained them kind of rest for 48 hours, then ease back in from a cognitive standpoint, followed up with them a week later, and they're still fairly symptomatic. At that point, call one of us, call a sports medicine physician in your community, say, hey, what should be my next step with this kid? Because we're always more than happy to work with people around us to help get these kids better, because we're just not going to be able to see all of them. Kids that don't get better after that first 2 weeks, about 10 to 20% of them move into that post-concussive. ICD-10 and then DSM-4 both have their guidelines as far as diagnostics. But if you're getting into that prolonged state of recovery, if they're symptomatic for an extended period of time, you're gonna have to treat this more as post-concussive, and it's starting over from a treatment standpoint. So you're reassessing where they are at their baseline, and then getting involved from a therapeutic intervention standpoint. I'll need to get through that. So second impact, again, we kind of talked about that. It's that increased intracranial pressure in a hypermetabolic state. And it's an injury sustained while you're still recovering from that initial injury. These are catastrophic. It's 100% morbidity, 50% mortality. So I'm serious when I say do not let your kids return to play until they're fully recovered. Long-term outcomes with your concussed athletes. I think we've all heard of the movie that sensationalized concussions. I think that did the general population a disservice, because everyone has this perception that a concussion creates long-term outcomes. What they're talking about from a professional football standpoint is subacute, repetitive microtraumas. So thousands and thousands and thousands of hits to the head over an extended period of time. You don't have to have a concussion to have CTE or long-term problems. Long-term outcomes from a concussion, we don't have the answer to that, because I think we're just, as a community, really looking at what having a concussion means for kids 20, 30 years down the road. Now, kids who aren't recovering, yes, they are more apt to have mental health issues, chronic migraines, learning disabilities, but these are also kids who either had subclinical symptoms prior to their head injury or were diagnosed prior to their head injury and they were just exacerbated. So that's why those red flag questions I mentioned at the beginning become that much more important, because if you understand this kid had some ADD, ADHD issues, or they had some anxiety, depression, that needs to be on your radar to manage that going forward with their head injury, and just be that much more hypervigilant about getting them involved early with the right specialists to address those. Don't just ignore them as, oh, that's part of their concussion. So I talked about this idea of cognitive rest when they had their first kind of concussive symposium, and this has become a thing every 4 years where all these people in the world get together and talk about concussions. This idea of cognitive rest, where you just kind of leave a kid at home until their symptoms go away, it's not how we treat these patients. Yes, that first initial time period, those first couple of days, you want to let them rest, but just shutting them down from a cognitive standpoint lets their brain just kind of stay as is. You want to get them moving, so to speak, with their brain in a graded method. One of the things everyone overlooks right now is that return to learn aspect. Everyone wants to talk about return to play, but I like to tell people they're student athletes. They're not just athletes. So we need to talk about how are we getting them back in the classroom. And this is where I've had the most struggle in my practice, is getting schools to understand, I want my patient at school, but I want you to follow the accommodations I'm sending with them on this piece of paper. The more they see my written accommodations, the more understanding they are at each school. But they're not educated in the administration level about how concussions are impacting their students. So how do we determine getting them back to school? Well, most of these concussions, their first visit's going to an ER or an urgent care. That's not going to be a priority for that setting as far as how am I going to get you to school? So they're just telling them to stay home until their symptoms go away. That's not the right answer. So inevitably, these kids are probably going to follow up with you guys a couple days after their ER visit, and your answer is not going to be stay home from school. I want to think we've taken something from this, and your answer is going to be, let's get you back to school, whether it's for one class a day, a half day, the full day, but nothing on the computer. And that's when it becomes that much more important to tease out what's causing your patient's symptoms. If they're getting a lot of light sensitivity and visual stimulus symptoms, you're going to tell them to stay off the screens. If they're complaining about noise sensitivity, you're going to say, hey, don't eat lunch in the cafeteria. If it's a fatigue issue, tell them, hey, go do work in a class for about 10, 15 minutes, take a break, work for about 10 to 15 minutes, take a break. If you can do that for one class, then come home, great. Because what happens is if we don't let our kids go to school, all we've done is isolate them from their support group. Because middle school and high school kids communicate with their peers. And as soon as you've removed them from their peers and they can't text them and they can't have that interaction, you now have magnified their anxiety, their depression, their fear about falling behind in school, and then you're exacerbating their concussive symptoms and prolonging their recovery. So we like to, let me get the slide. I like to look at this cognitive activity scale and break it down as far as where I think they are, what I think they can do. And then I will make my recommendations for them to take to their school based on this. And if you look at a study and you break down where they were on that cognitive scale when they went back, kids that went back too aggressively from a cognitive standpoint had a prolonged recovery, but kids that didn't go back and stayed and did either homebound or a 529 from the get-go, they had a prolonged recovery as well. So they have to be 100% symptom-free to start their return to play, but they don't have to be 100% symptom-free to start that return to learn. And I recognize that a concussion visit takes a lot more time than the 10 to 15 minutes that were budgeted. These are patients we often will spend 45 minutes to an hour with just from an education standpoint. And I know that bogs down your day, but these are the patients that it really pays off in the end to spend that time with them and educate them. And every student athlete that you spend that time with, it becomes that much less time that you have to educate them because they're in that school system and the schools are beginning to understand, and we're kind of spreading that word out. This is a good breakdown as far as that return to learn, that no activity that first 48 hours, a gradual reintroduction of cognitive activity. And I'll even say, if it's somebody who just is like, I can't go to school, I'll tell them, that first week, do puzzles, 5 to 15 minutes, do coloring, do something that you're engaging your brain into an activity, and do it, 5-10 minutes, take a break, 5-10 minutes, take a break. Light reading in a magazine, but get their brain going. So again, half day accommodations, full day with accommodations, full days without accommodations, and then that full school extracurricular involvement. So general concussion accommodations. The biggest thing is understanding being sympathetic, listen to your patients, but getting their parents to understand that they need to be sympathetic. You're going to have a moody teenager, you're going to have a sleepy teenager, you're going to have to advocate for them at school. And I don't generally like to tell parents you have to get involved and hover, but sometimes parents need to go to the schools and sit down with the guidance counselor, or sit down with the teacher and say, hey, this is where we need to make some accommodations for them to be able to stay and get through the educational process. Prioritize, so putting certain classes ahead of others as far as ones they can go to. And then I usually will say, like, no more than one test per day. So if it's exam season and they're supposed to have 3 exams that day, I'll say they need to do one Monday, one Wednesday, one Friday, and I'll be that specific when I give my guidelines. A good way to determine kind of where they're struggling or what things are causing them cognitive symptoms, send them with a cognitive activity monitoring log, and they can track what activities from a school standpoint are aggravating to their symptoms, and that will help you that much more make your accommodations. There's also a good resource through Nationwide Children's as far as teasing out where their cognitive symptoms are coming from. And then other conditions that kind of contribute. We've talked about those migraines, the sleep disorders, and the emotional disorders. Don't ignore those. Make them part of your assessment, part of your treatment plan. And you'll find by the time a patient gets to us in our concussion pathway, we end up having counseling involved. We end up having vestibular therapy involved. We end up having ocular therapy involved. We end up having physical therapy involved. And you're keeping track of all these places that these patients are going, but it's to treat kind of each branch of that concussion. So, I can't emphasize this enough. Educate the families, educate the athletes, pass on the education to the schools, pass on the education to the coaches, because there is still an abundance of people involved in athletics or involved in education who don't understand how concussions are impacting our students and our young ones. Understand how to manage their OTC medications, emphasizing Tylenol. And I do like to tell them I don't want them taking it more than 3 or 4 times a week. I want them to limit how much they're trying to suppress that headache. First of all, I want to know where they are. Second of all, I don't want them to end up in rebound headaches from too much over-the-counter medication. If this is a student athlete who's had multiple concussions, you need to start having a different conversation with them. Do we need to look at a different sport? Because we know your recovery is going to be extended with each concussion that you have. And then that physical rest on the front end, and then getting the moving, that cognitive rest on the front end, and then getting the moving. So, in summary, when in doubt, hold them out. If you think they have a head injury, if you think they have a concussion, do not let them return to play. They must complete their return to play protocol. Getting involved with the school is an important aspect. No 2 concussions present the same. No 2 concussions heal the same, even within the same patient. They're going to look different every time. Communication is imperative with these patients. I try to give them as much written information to the families as I can, because they generally, the athlete or the student is not going to remember the majority of what you said in clinic because they're concussed. The parent is worried they're not going to remember the majority of what we talked about. So trying to give them written information is important too. And then your education, your knowledge of concussions becomes that much more empowering in being able to care for your patients. Thank you.
With your evaluations, I know several years ago, drospirenone OCP was a banned substance for NCAA. Spironolactone, we're taking care of a lot of patients with PCOS.
Any of our student athletes at USC, obviously we get a comprehensive medication list, and then I specifically ask them about over-the-counter medications and supplements, because everything needs run through World Health Organization and all the IOC anti-doping. NCAA has a list of banned substances. IOC has a list of banned substances. Especially In your high school and college athletes, you're going to have a lot of kids who are doing Olympic development. You're going to have a lot of kids who are doing Olympic trials, especially swimming and track, that if you're not aware of the banned substance lists, you're going to get your kids in trouble. That's why I emphasize the ADD meds tend to be the biggest implicator, because nothing infuriates any of us more than you've asked a kid 10 times if they're on a medication, they say no, and then you're at the NCAA tournament and they pop positive for their ADD med, and they say, well, I've been taking that since I was little. Well, it still counts.
How do you possibly work with the phone? You're telling a teenager not to use their phone for 48 hours to text?
So that's a great question, because if they're not on their phone, apparently they can't communicate.
Right, they can't open their hand.
Yes. What I will tell them, because again, cutting them off from their peers becomes very anxiety creating for these kids. So I will tell them, please don't get in a live streaming, don't get into a 4-hour text conversation with your boyfriend. Quick text message, put the phone away. The best thing you can do is text your friend and say, hey, I have a concussion. It bothers me to be on my phone, but if you need something, call me. I try to encourage them to call each other, but I don't ever just 100% take anything away. I just try and limit it and explain to them baby steps with the phone. So little text messages, and then, if it becomes an issue, I tell mom and dad, if you need to take it and put it away for an hour and tell them to go lay down, do that, or supervise time on the phone for about 10 minutes. But it becomes a risk reward of, do their symptoms get better if you take their phone away, or are you actually making them worse because they're just anxious and stewing in it and worried about what's going on with their friends, and that's making their concussive symptoms worse. So finding a balance, and that's a long conversation I have with them in clinic.